at home and in the United Kingdom. Today is the momentous day, and it is an ongoing relationship with the Indian Association of Gastrointestinal Endo-Surgeons and the Association of Laparoscopic Surgeons of Great Britain and Ireland. This relationship is nurtured over the last 5 to 7 years, and it has evolved into a hugely mutually benefiting academic exchange. Today, the theme of hernia. I'm sure the upcoming 90 minutes will be worthwhile, and I'm sure will be very interesting as we have very nice cases to be discussed on the management of complex hernia. Ladies and gentlemen, as a matter of custom, the meeting is begun with a welcome address by the President of the IAGS, Dr. Subhash Agarwal. Friends, for the new friends who have joined recently, I'll be briefly introducing Dr. Subhash into minimal access surgery as early as 1990s. And before even structured training came in, he used to take short-term fellows to his center for a month, 6 months like that. And he has trained now more than 900 surgeons across the country. And he's instrumental in bringing in laparoscopic training program, live demonstration at even Tier 2 and Tier 3 cities in India. He has regularly contributed to the textbook of the IAGS, and the most recent contribution is minimally invasive surgery for acute abdomen. An eminent surgeon by himself, very ardent speaker, and he takes care of all of us and he guides us for medical legal issues and social issues of the doctors being faced across the country. A versatile speaker and a versatile leader. The last 1 year, IAGS has seen more than 40 short-term courses, and IAGS was privileged to host the World Congress of Endoscopic Surgery under his leadership. Thank you, Dr. Subhash. We look forward to hear you and bless us with the beginning for this humble evening.
Thank you, Dr. Kanakwal, for the kind words. IAGS and ALSGBI, we have a relationship which is much beyond the academics. I always say, GS is just like a family. And same kind of relationship we share with the ALSGBI. Recently, when I was to attend ALSGBI conference, and the kind of response we got, Dr. Ishwar Murthy was there also along with me, our president-elect, Satish Midda. We were all together. And the care taken by them was excellent. It was just, we never felt that we are away from home. As far as academic is concerned, both IAGS as well as ALSGBI thinks beyond our mentor or father of laparoscopic surgery, Dr. Hampton Udwadia, when he formed this association, used to say we have to take this laparoscopic surgery to every nook and corner. The past presidents who have led IAGS have contributed so much that we are a strong association of almost 14,000 members. And all members are so happy about the contents of the fellowship courses which we regularly conduct, whether it's the basic or advanced courses, that they always look forward to the next program. I received call from Hyderabad that you are going to organize this robotic falls program in Hyderabad. And so far, we haven't received any communication if you have comes all across from all across the countries and now the neighboring countries where we have association, whether these are the SAARC countries or beyond it, be it Malaysia, be it Maldives, everywhere we have collaborated, and our aim is very clear that the knowledge which we have, we share with each other, we learn from each other's experiences, and we are always learner because things are moving so fast all across the globe that we have to be well versed it. When we started laparoscopy, it was basic. There was no training program. Nobody knew anything about it. And we learned from our own mistakes or interacting with each other. And now there are so many facilities available and we are trying our level best. And I compliment Dr. Ishwar Murthy along with Govindraj and our mentor, Dr. B. Krishna Rao, that we have now started the endoscopy programs also. And recently we had a simulator for training surgeons in endoscopy, which was inaugurated in Chennai recently. And Kanakvel was the instrumental in that. And the way we are thinking, and we always that from each other's effort, and that's our aim, and that's what we are doing. And for organizing this program, Dana and Kanakvel is definitely they have worked really hard. And the program which has been designed is going to help everybody. And I wish you all the best. Thank you very much.
Thank you,
Dr.
President.
Kanakvel.
Yes, sir. Thank you, sir. Thank you very much for your kind words. I'm sure IAGS will reach more greater heights. And then we are eagerly looking forward for the Nepal meeting, which is happening under your leadership at Kathmandu. Can I have the pleasure of inviting Dana to introduce the representative of the ALSGBA International, Dr. Shafa.
Good evening.
Dana, please unmute yourself.
Yeah, good evening, everyone. Many thanks for such warm welcome, and I can only echo that because the relationship has gone between EAG. I greatly appreciate your ongoing support and also the team effort to learn from each other. And it was also say that it was very, very mutual. I'm very happy that as the ALSGBI webinar lead, I can support this learning environment in any way. And my thanks efforts about ALSGBI. She is such a role model for many people in the UK. She's working consultant colorectal and general surgery. She specializes in robotic, and she holds many chair positions at the Grampian Robotic Governance Committee, as well as the research and the floor is yours. Thank you.
Thank you very much, Dana, for the kind words and the introduction, and well done both to Dana and Kanagavel getting this amazing program together. Of course, Professor Tan was unable to attend today. Prof. Sekar is here, and he's another great role model and somebody who is also a mentor. Agarwal just highlighted it's not so much of a society as it is a family. It's led by some highly motivated individuals who are not just exceptionally skilled, but exceptionally humble and down to earth and open to training. And one of the vision missions of the society is training and education in minimally invasive surgery. It was founded way back from the name, as you can imagine. It's an association of laparoscopic surgeons, but surely the remit doesn't stop at the level of laparoscopy of how we are about training. The society news courses throughout the year, including the legendary LAPAS course, and now increasingly we are developing numerous robotic surgery courses from the elementary level to the advanced level. So I have given this effort to the topic today, and also I'd like to touch upon a point over here away from this to a successful start. Thank you very much.
Friends, to honor, invite
to power of IAGS, Vice President of South Zone of IAGS, and he is a robotic colorectal and hernia surgeon. And if you watch his YouTube videos, I think they are treated to watch. There are so many followers to see the technique, the way it is. Come him. Ashwin?
Sitil, can you look into the video, please?
Are you able to see the screen, sir?
Yes, 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 yes.
Again, it went.
So, a small opportunity to talk on eTEP Inguinal with you all in this evening. So, the E in eTEP stands for extended or an enhanced view. So, the main advantage which we get with an eTEP is that we have a nice panoramic view of the advantages. By that is, one, we are able to appreciate the various planes. So we know there is a pure preperitoneal plane. There are 2 layers of transversalis fascia. Then you can also go close to the anterior abdominal wall. All these planes are a little more difficult when we do it with the conventional TEP. Sometimes you get these planes very well, sometimes you miss them. Whereas in eTEP, there is a get these planes more often than not. And since we have a larger space available for us to dissect, it also tolerates the pneumoperitoneum a lot better. So even if you have a small buttonhole, the loss of space is not as much as compared to a conventional TEP repair. And the learning curve to perform a purely extraperitoneal compared to a conventional TEP procedure. Also, we have to emphasize that the camera assistant finds it a lot more easier to show the camera in a precise manner in a eTEP compared to a conventional TEP surgery, because a lot of things are claustrophobic in a conventional TEP, whereas in eTEP you have a little more space and distance available between the a better orientation since you're a little more further away from the target organ. So when we look at some of the disadvantages attributed to eTEP, one, we dissect a very large space compared to a conventional TEP repair. So this people feel may be a overkill, and what we have started to do in our practice, as well as a lot of other high volume surgeons have started doing, is they've started to restrict the amount of dissection we do corresponding to the hernia which we are repairing. So that way unnecessary space dissection can be reduced. Element of division of the posterior rectus sheath during the initial phase of explanation and how they were presented in the paper of eTEP. But now, as we have got familiar with the procedure, we know this step is not really necessary in majority of the patients. Probably less than 1% of the patients only would require a small division of the posterior rectus sheath. And even the division of the arcuate line can be. So one of the major advantages of a eTEP is that it gives you a lot of versatility in placing your ports. Say the patient has a bilateral hernia. Me being a right-handed surgeon, I would prefer to enter into the left retrorectus space. So here you have the versatility to take 2 centimeters above the umbilicus and 5 centimeters lateral to the midline, as described by Professor Orgade. This is quite optimal to place your camera port. Of course, this varies depending upon the build of the patient. If the patient is very short, you would go a little more higher up. If it's a taller patient, then probably you would come down a little more. So here is we would go laterally similar to it so that we are in the retrorectus space and that can be extended into the preperitoneal space. So once we have this landmark marked, then we enter and make our first working port, which will remain as the camera working port. And the port position which I'm going to show you today is what we commonly use in our unit, which we will buy all the younger residents as well. So after making the first optical port, we do a little bit of dissection of the retrorectus space. We don't all the way to the Coopers, rather we just stop our dissection near the arcuate line. Once the dissection is done till that, then epigastric port, and probably in line with the umbilicus or slightly lower, less than 2 centimeters from the line of umbilicus. So that would be our second working port. And once our second working port is made, under vision in a sharp manner, we dissect the lower abdomen and we open up the retropubic space of Ritzius, and we also do a little bit of a crossover similar to what we have dissected here adequately. Then we will make our second working port, which would be around 2 centimeters lateral to the umbilicus and 2 centimeters below the line of the umbilicus. So this port configuration gives you a good triangulation for you to work immaterial of the side of the hernia. Even for a left-sided hernia, this port is good enough. Even for the right sided hernia also. I'll just share you clips highlighting some advantages of understanding the planes and what are important in eTEP. So this is the first video regarding the axis. So either we can do a open axis similar to how we are used to it, or we can also use an optical trocar. Here you can see the target sign, that's the posterior rectus sheath and the rectus muscle seen well. So once you see the posterior rectus sheath, after you go in, you can see this is a nice plane which we have dissected, but we have to be very, very careful because it's easy to lose the plane and enter into the abdomen. Then it might become very challenging for you to proceed. So for the initial cases, it's better to do an open axis. So next, I just wanted to highlight some of the planes. So why we don't like to do a telescopic blunt dissection. Here you can appreciate dissection. This vessel is put on the roof, but all this dissection is not really controlled, and it's more of in a blunt fashion. Sometimes we'll be able to get away with it, like in this case. So here you can appreciate the plane well. This is the muscle which is bad, the Brooks artery. Leave this fascia and the fat with the anterior abdominal wall, and our dissection is always slightly lower. So once you make an incision, you can see now the true avascular plane opens up. And this is nice fluffy plane which is available for us to carry with. You don't see any major vessels running in this plane. It's always small branches which are present. OV for you to do the dissection and take down these vessels and also open up these planes very rapidly. And as we come to the midline, this is what I was telling you about. This is the fat which is always constantly present. So here we again have two planes. You have a plane lower down, or you have if it's a thin peritoneum, we go slightly higher up, so you don't leave too much of fat on the anterior abdominal wall. But if it's a thin patient, patient with a lot of peritoneal fat, then we can go posterior to the fat and open up the planes. So this is the inferior epigastric which we see over here. So this side, since we started from the left side, only then we would make a second working port. And after making the second working port, immediately we will open up the lateral space of Bogros. So whenever we are opening up the space, you always make sure that the peritoneum from close to the inferior epigastric is pushed down so that you do not cause any inadvertent injury to the peritoneum. And when we do the parietalization, care has to be taken that you own peritoneum. We don't see testicular vessels. Rather, we just peritoneum and the vas and the testicular vessels can be preserved. So if you preserve this fascia, that can prevent a direct contact with the mesh, which can reduce the incidence of chronic groin pain in these patients in the posterior and the lateral side also. We always hug the peritoneum and try to do all the dissection close to the edge of the peritoneum. And whenever we do the cautery, we should not divide and incise the fat over here. So here we will have the duluxia and try to serve it and stay and posterior to it. So now you can see that is the anterior superior iliac spine. This is how the view would look like. The bladder you have dissected 2 inches below the corpus. These are the anastomotic veins between the obturator and the external iliac, the veins of Bender. So you don't have any fat surrounding the obliterated umbilical artery, which will be our infromedial limit. And that along with the testicular vessels will form the triangle of doom. So you'll have the external artery and the vein as a content in this area. Here you can see a fascia covering the nerves. So just, and this is the into the inguinal canal anterior to the iliopubic tract, because that is the lipoma of the cord which has to be reduced. Once all these steps are done, then that means we have finished our dissection and we have gone to the end of the dissection. Then we can plan our deployment of the mesh. So what are the other advantages we get with eTEP Inguinal? See, as such, Ashwin is handy for us to take a purse string suture, anchor this transversalis fascia to the anterior wall or abdominal muscle. That way, we entire time we give a good flat interface for the mesh to integrate into. And even in cases of very large complete inguinoscrotal hernias, having the camera higher up gives us a nice panoramic view, similar to what TAPP repair. So this is even very level, but since this is a larger space which dissect, we don't lose pneumo and we're able to proceed. So you can, and then we can suture close that defect either using a barb suture similar to what we have shown here, or a conventional PDS suture. Running suture is good enough to close this area, so that easily reduced in a eTEP without much challenge. So these are some of the advantages which we are getting with the eTEP, a lot more easier to do these dissections. Thank you very much for your patient listening. I'd be happy to take any questions you guys might have.
Explanation as soon as try to come in. You were
compared to a TEP. I mean, whenever the patient has got a short pubis to umbilicus different distance, eTEP definitely has a greater advantage to a conventional TEP. Very well.
Thank you.
What will be for the people? Recommend to do few TAPPs and TEPs before moving on to eTEP. What is your recommendation?
So in an ideal scenario, yes, we would recommend them to have some exposure to TAPP repair, because that is a larger space which is familiar to us. We enter into the day in and day out for procedures like appendectomies or cholecystectomies. One would proceed this, since everything is right before your eyes. You know if you have dissected and reduced the entire hernia sac, or still there is a small sac which is protruding in, which you have probably missed out. So unless you're familiar with your easy hernial sac and also plain way. But once you get familiar with the planes, then yes, eTEP makes your life a little more better, since you don't enter into the abdomen. The bowel returns quicker, and the chance of an ileus and all that is much more less compared to a TAPP repair.
Thank you very much. Faculty here, would you like to give your comments, or would you like to ask any questions to Dr. Ashwin?
Ganesh, can want next speak and have calculated also.
Thank you very much.
Friends, yeah. Take over. Please.
Thanks, Kanagiri. Thank you very much. So it gives me great pleasure, Srinivas Chintapatla, who has kindly accepted this invitation despite being on call this weekend. Dr. Chintapatla, he's been a surgeon for 20 years now. He's graduate John he then headed west to the UK, where again exceptional career and is not something you'd find simply among surgeons. He has a specialist interest in abdominal wall reconstruction, and he set up the York Abdominal Wall Reconstruction and also liaison with the British Society, and at a personal level, he Dr. Chintapatla.
Tell me, please, Shafak, if you're able to see what I have.
Yes, indeed.
Yes. Okay. All right. Yes. Okay. That's great. So I'm Srinivas Chintapatla here. This is and then in Coimbatore, where I worked with Dr. Palnivelu when he did the first lab coli. I remember that very clearly. It was a demonstration one. So it's many, many years of love I have received from mentors in India. After finishing my that I've come to UK as Shafak. So here at your setups. I start with proposition that abdominal wall hernia surgery is for improving quality of life. And if that is accepted, then I'm bringing something which is a little controversial, which is that big cases may need big in 15 minutes abdominal wall hernia. So here is a gentleman who's 71 years old and back in 2014 had a robotic prostatectomy, and 48 hours later came to our hospital with necrotizing fasciitis, which went on to have about 5 laparotomies, skin grafting, extensive abdominal wounds. What you can't appreciate are the 2 gauze pieces, which are basically holding on fecal matter, which is coming through groin incisions, so intestinal fistulae. And you can see the pendulous abdomen from the post-laparostomy, with the rectus muscles having gone laterally. A point to make is that when gravity acts, I find the dynamic hernia assessment works the other way around, because when you do this, you may be able to see how much that retraction can be reversed. And that gave me the confidence back in 2016 or so when I operated, about being able to take on something before the era of PPP. So here we have the dimension, and this is the days. Appreciate the of space. We worked him up for his intestinal fistula. After the sepsis and nutrition is sorted, we go on to the anatomy distinction, and you can see the little catheter going in interventionally, and the dye being and identifying small bowel. And entering and going out of the right groin, whereas another entering from the left and again coming out of the right groin. And so the fistula was being fed by small bowel, and a resection anastomosis performed. There's the specimen. The histology was unremarkable. And here, back in 2016, I felt a mesh being utilized, but yet the interictus separation is huge. So here is the medial attachment, and I've created a plane between external oblique and internal oblique over here so that the extended anterior component separation allows medialization. The medialization happens. And I see the urine dipping suddenly to 10 mils per hour over continuously over 3 hours. That was what was being created. And that's when intra-abdominal hypertension might change into abdominal compartment syndrome. But of course, in this situation, by we were and I tried to get photographs post-operatively as a way of auditing my own results, and dynamically, functionally assessing the abdomen with leg raising tests, as you see, post-operatively. So here's another lady where I'll show a slightly different tag, somebody who has a open cholecystectomy, abdominal fashion, their own incisional hernia repair. So recurrent assaults on the abdomen, a lot of comorbidities on apixaban with morbid obesity. And I put her through the prehab program and achieve about a 20 kilogram weight loss. We have an 8-week prehab program over here at York, which is based upon changing behavioral manipulation so that they go on to eat less, walk more, exercise more, build up muscle, overall be my drop. This is homage to Tom McLeod, who's plastic surgeon I work very closely with, and his multiple drawings he makes before before attempting to excise and resect excessive skin and subcutaneous tissue. I want to show this emerging idea of fasciotens from we've been lucky to partner with Gary on Lil, who actually surgical involvement, the fleur-de-lis incision, and the final abdomen, which has been created. We tend to use a lot of negative suction for wound therapy management. And the last case, which Elpida will very kindly go through for us, shows another large hernia where we follow a protocol of weight loss, followed by a prehab regime, followed by Botox, improve the patient's quality of life. And I'll digress slightly about that. To answer this, the question, we need to know how you measure quality of life. And when we did a literature review over 5 years, with the last search being in March of on the left-hand side of the slide, or pain-only tools, body image tools, and so on. But abdominal wall hernia specific quality of life tools, there's 6 of them. So we went on to analyze all of them using this well-validated Cosmin method. And it looks at psychometric properties such as validity. Looking at that, we also looked at how the tools were developed. And we found that a consistent theme was that very few patients, if at all, were involved in the development of these tools. And psychometric analysis brought this issue quite to fore because of morbidity. Had sociologists in it, a surgeon who had done qualitative research, and an academic fellow. We've gone on to publish about it, but I'll describe what we have done to a certain degree. So in UK, MD is a research degree, which is about a 2-year program, and my researcher was Olivia Smith, and that's her York. There are 2 research universities, and we picked phenomenology to study this phenomena of quality of life. Purposing sampling was performed so that all kinds of patients were included. Data collection was by 2 hours semi-structured interview, which is recorded, then analyzed, which is anonymized, transcribed, and finally hundreds of transcripts are created and interpreted phenomenological analysis reviewed with a sociologist. For example, the thematic theme saturations all happened by 6 patients, all the patients which carried out doing the work. And this is the images, and if you look at the green line, those are the areas that patients tell us. Symptoms, mental health, body image, they don't tell us because they don't think that others would want to know. It's a world they have created for themselves. And then we talk about the sub-themes, the subordinate goals, and I'll build it up and deconstruct this. So there is one area of symptoms and the function and how they adapt. And they talk about pain, but also freedom of movement in great detail, and found things like shame, shock, guilt, disfigurement, but also positive coping mechanisms from family, from social support, and surgery has a huge role. Body image, which becomes a big issue in terms of either how they feel or how they think others feel when they look at them. It's judgmental and involve both sexual relationships and social relationships, and we've worked on this. We presented these three papers and brought out, and we are recordings and transcript and what the patient writes for us, and he tells us later on that his mental health has improved, divorce is no longer an issue, he enjoys life and feels comfortable enough to say that he enjoys sex. A big thanks. Very
Thank
happy
you very Yes, thank you very much. The thing that's in your talk is the fact that the actual skill and the cutting that we do as surgeons is probably just a very small slice of the And I think the real mastery comes when you kind of transcend into touching patient.
Wall reconstruction. Europe in Kent said we don't just reconstruct abdomens, we reconstruct lives. And that really touched me when he said that. And it's something what you're saying as well.
Yes, very true indeed, very true. Thank you. I think we move on to the next presentation. Is that right, Kanagaval?
It's been a pleasure to maintain for your own patients. Definitely inspires all of us to improve our data keeping, and I'm sure that will be for the benefit of our own self and for the academic interactions. Thank you very much. Sir. Now,
You're very
friends, now about 20 to 40 minutes. So there is going to be a presentation from India, and there is going to be a presentation from the United Kingdom. And we have eminent experts here who will be chipping in and interacting with the way how the cases are being managed and how better or why. Dr. Nidhi is very popular surgeon, hernia surgeon, and she also has special interest in bariatrics and general laparoscopy. She is a very ardent, advanced foregut surgeon as well. And she's a good friend, and she's been associated with IAGS for more than a decade now in active academics. Ladies and gentlemen.
Sorry, am I audible now?
Perfect. Yes, go ahead. Good luck.
I was just thanking you for that very sweet introduction. And I think the part which touched me the most was you calling me a good friend. Good evening, everybody. I'm Dr. Nidhi Khandelwal. I'm a laparoscopic and robotic bariatric and general surgeon from Mumbai. And today I was asked to present a case on inguinal hernias. And I was told that, it does not necessarily have to be eTEPs. And I must honestly confess, 99.9% of my practice is probably TAPP surgeries. As Dr. Ashwin mentioned, that is what I'm most comfortable with. It's a very familiar anatomy, and somehow I have not yet found that reason in my own practice to switch over to a TEP or an eTEP, but of course to each his own. And today when I was asked to present a case, I was really just struggling to figure out exactly what I want to present. Because what I realized is that, the groin, it's a very, very tiny area, but in such a small area, there can be so many different complexities which a person can have to face at any point. Now, normally what you would like to see is, something like this, which is basically, they are cute little direct hernias. They're completely reduced just with pneumoperitoneum. There are absolutely no contents inside. And it's just about difficult enough that, I'll give you the thrill of a surgery as well. And you know that this kind of a patient will do well. But unfortunately, what actually normally happens in life is something like this, where, even though this looks like a very innocuous direct hernia, when you actually look down, you're seeing some angry red looking bowel over there. And while this bowel is still viable and, it's not obstructed, it's not strangulated, nothing else has happened. But when you see these kind of cases in your initial practice, you tend to start thinking, oh God, what should I exactly do further now? How exactly am I supposed to handle this bowel? Of course, if there is some obstruction or strangulation, your message is very clear. You got to do something else with the bowel and forget about the hernia for the time being. But at times, I've come across some cases like these where it's a large defect and it seems like there is just this endless loop of bowel which is just going in, and no matter how much you keep trying to pull this bowel out, initially it just comes out with some amount of ease, but eventually what happens is at some point you start feeling a tug. You just feel that it's now not coming out quite easily. You're seeing over here on the lateral side as well that it's probably the colon also which is going in. I'm thinking in terms of an Amiens hernia as well over here. And I try to change the direction in which I'm pulling the bowel, and at one point I noticed there is some kind of a small serosal tear also which has happened. I once again shift my angle, just recompose myself. And over here, whenever I'm doing this particular step, I have to be very careful that I don't apply too much force on the bowel. I have to basically try and pull it out in exactly the direction in which it's going to come out easiest. And this counter pressure, which is being offered by my assistant from outside, is probably what is actually going to help me more than anything else. So rather than doing a lot of pulling and pushing, this gentle traction and counter traction is the movement which you actually need to master when you're handling such difficult hernias. Now you can see that it seemed endless, but of course there is an end to this sac as well. And once you've got all your contents under control, you go ahead and you perform a hernia repair the way you would always like to. Sometimes on one side there might be just a very small tiny looking hernia, but when you actually just focus the camera to the other end, you'll find that there is some kind of a chaos which is happening on the other end. And that's what happened, and this was a very recent case. This patient was basically already planned for an elective inguinal hernia repair, but he suddenly came and got admitted in the middle of the night with irreducibility and some pain. And we took him up for surgery the next morning, and once we put a scope inside, the bowel was viable, but you can see evidence of these chronic interbowel adhesions which have formed because the hernia was too long standing. Now we're examining the mesentery, which is looking a little inflamed. It's important to just flip over and check the mesentery and the bowel from both the sides. Make sure that you're not missing out even a small patch of gangrene or anything else. And as you'll see even more carefully, the small bowel was actually forming a part of the sliding hernia sac. And sliding hernias, as we all know, are very difficult. Sometimes they can be very complex to handle, and they tend to cause a lot of distress. And plus, here in this particular case, you can see how inflamed the sac is as well, and you can see the chronicity and the fibrosis all around. This was another interesting sliding hernia case which we came across. Again, what you'll notice over here is that the sac was very, very thick. Normally we keep getting upset that the peritoneum is too thinned out, and that is why rents happen in the peritoneum. But here you can see again, because of long-standing issues, the peritoneum was thick, the sac was very thick, and the sigmoid colon was forming a part of the sliding hernia over here. Now, as we're trying to just dissect the sac a little bit and take it away from the cord structures, we landed up opening it up accidentally. And we thought over here that we have a lot of space. The sigmoid colon is far. We can just cut this sac. But as we started doing that, as it always happens in sliding hernias, all of a sudden the sigmoid colon was suddenly way too close. And now, because of this awkward position in which we had cut this sac, we created a very, very huge peritoneal rent somehow. We fortunately managed to escape without any kind of a sigmoid colon injury. And because of a little bit of background of some more colonic dissections, we could create some more mobilization of the lower peritoneal flap. We excised whatever was this little dead isthmus of peritoneum in between. And now we plan to close this peritoneum in like an oblique V kind of a situation. And after placing the mesh, we just started our normal closure. But in between, we realized that, we will not be able to stick to our original plan of suturing. We'll have to do something a little different in this case. And because the lower flap was so excessive, it was completely lax, we just decided to take a purse string suture. And over here, you can appreciate how close to the colon I had come. Fortunately, there was absolutely no injury. The patient did very well. And we could get away with some amount of innovative suturing over here. And once we closed this peritoneal flap, there was a small rent which was left in between. We closed that too. And you can see the eventual look. The right side was operated as per normal, and the left side also eventually we could get away with good closure, simply because we could just keep a calm and composed mind at all times. We also had a case of a recurrent hernia. This was after an open inguinal hernioplasty, which was done 15 years ago. And you can see over here medially, I'm doing the right side first. You're beginning to see the old sutures over there. This is more of a supravesical hernia which has developed in this patient. Sometimes, as is the dictum, you have to try and locate the virgin plane first. So we went more medial, and then we could actually dissect that sac out completely. There was a small indirect component as well over here, so we're trying to dissect it. And this is just how I usually would do all my TAPP dissections, which is to make sure I'm giving proper traction with my left hand, and just keep dissecting the fat planes away and try and go all around the sac while trying to push the cord and the cord structures behind. But here it looked like I've gone all around the sac, but what had actually happened is that I took the vas as well as the cord structures along with me, along with the sac. There was a very ill-defined plane over here, and I had to use my left hand a lot for dissection. So a lot of ambidexterity which came into play over here. And once I actually managed to completely parietalize the cord, you can see I've gone all across the sac. It was time to just cut this sac and move forward to the next phase of the surgery. And now I'm beginning my dissection on the left side. I particularly wanted to mention this case because later on I went through the previous discharge summary of this particular patient. And this patient, like I mentioned, was operated 15 years ago for a bilateral open inguinal hernia. And what I noticed was that he was operated during my residency, and it was my handwriting on that particular discharge summary. And I was involved in this particular case at that time. Of course, I did not have memory of that time, but it was just a twist of fate that when this patient had a recurrent hernia, he came back to me, and I hope that this time I've given him a much better repair than what I did before. Here again, you can see on the left side, I actually just went ahead and dissected whatever planes were much easier to dissect, and then I moved forward to whatever was the fibrotic area, and just slowly, gradually, under complete vision with proper assistance from my camera surgeon, I could completely dissect out this sac as well. Wherever required, just keep cutting all of these fibrotic bands, and these are the areas where you should not try and be too pushy, and you should just slowly, sweetly take your time. Just do everything under good vision and with good control. And if ever you get stuck in any kind of a situation, always call for help. The other thing I would like you all to notice in this case is that whenever I'm doing a TAPP, I don't like to take a very, very big peritoneal cut. So the lateral extent is never up to the anterior superior iliac spine. It's usually around a 4 or a 5 centimeter cut. And if you actually maintain your planes of dissection and your camera surgeon is just as trained as you are, you will be able to actually get away with these smaller peritoneal incisions, which are eventually much easier to close. Finally, I'd just like to show you a case of an obturator hernia. This was very early on in my practice, so I apologize for the poor quality of this video because it's a very old video. And when I took up this patient for surgery, I knew that there was a groin hernia. And at that time, the patient just gave me a history that, he keeps getting some kind of a weird sensation on the medial side of his thigh. He said sometimes it pains, sometimes it's just unbearable pain. And I told him that, it's okay, it's, probably something unrelated. We'll figure it out a little bit after your hernia surgery. But while doing the hernia surgery, I noticed that, there was this pad of fat which was creeping into the obturator fossa. And as is the dictum, you're normally not supposed to dissect this out. But I remember the patient's history at that point. And when I went on dissecting over here, and I was just doing it very softly because that this is the area of the corona mortis. You don't want to injure any vessels over here. As I was doing this, I noticed that there was a small pseudosac, and this was probably what was compressing the patient's obturator nerve. And basically, what happened is that once I could actually get this entire pad of fat out, reduce this pseudosac completely, the entire obturator vessels and nerves were very well exposed. And post-operatively, the patient actually did not have any further pain along the medial side of his leg. And that's why I think, this is where no matter what you'll end up doing in hernia surgeries, history taking somewhere has a very important role. It's important to listen to every patient because they all have a good story to tell. And this is exactly how you learn and you keep growing in hernia surgeries. So you can see over here, I've managed to practically reduce all the contents, and now the vessels and the nerve are very clearly visible. Fortunately, absolutely no bleeding in the field. And you can see how deep the defect actually is. Practically my entire instrument is going inside. So basically what I just wanted to show with all of this is that this is all just a drop in the ocean. These are just a few of the case scenarios which people can come across. Essentially, groin hernias can be full of multiple surprises and a lot of challenges as well. But as we keep doing more and more, we keep learning more and more. Thank you so much.
Thank you, Nidhi. That was wonderful. I think you had a galaxy of cases with a lot of challenges. I think, like you, I started doing tap only mainly. Now still, though, it's very looking at the Ashwin and Ganesh, and now it's very tempting to go into the other space. But once you're comfort and you are able to tackle most of the cases, why to change? So this is the thing I wanted to. I just want to ask because there are some situations where corona mortis maybe there stagnate you or inadvertently you get damage and some bleeding, and how to come out of this tricky situation.
Right. Okay. So I have never had to be in that situation, honestly, because this is exactly one area where prevention is better than cure. I think the best way to first ensure that you're not causing any kind of injury is to make sure that you are training very well. So during your entire residency and whenever you're observing somebody first and learning from someone first, you please observe how exactly they do all their hand movements in that particular area. Like I mentioned, the groin is a very tiny area. There's very little scope of error. So even the slight of millimeters here and there can cause some kind of injury. So getting good control over your instruments, having complete control over your cautery, over your scissors, everything is what you first need to learn. The second thing is whenever any kind of bleeding does happen, you just follow the same dictum which is always followed, which is just give pressure first of all. So always on my trolley, I've got pieces of radio opaque gauze pieces which are always cut and kept ready. I always hope that I never have to use them. Happened if you think it is too major a bleed, you if it's not too major, sometimes just you can get with some amount of bipolar. If not, please not start in the area extremely, which is TAP search, probably choosing the mesh. Open. Have you know really mastered the art of fine dissection, and so I don't ever has to through that.
Thank you.
Is the best instrument if you want to secure hemostasis in these areas. And generally, when you're planning to fix the mesh, if you have a small vessel running close by during the early learning curve, I think it's a good practice to just bust them off the rubber cooper in a safe manner. It's better to bust them off with the bipolar. That's a very good practice.
Yeah.
Thank you. Thank you.
Thank you.
And Ganesh, would you like to add, or Srinivas?
Ganesh sir is on mute.
Ganesh is driving, I think.
Very good presentation, Nidhi. Nicely, very nicely presented. Regarding corona, I mean, these periosteal vessels or the near the Cooper's ligament, and we should tell them that not to rub over the vessels while dissecting. So these are the bleeders which are really very clot. Keep pressure over some time, at least for 5 minutes. It will stop.
Thank you. Thank you. That was a very good. Any other faculty would you like? Close friend from Wales. We met every time when I come. I in the Newcastle. When we did the ALSB, also in the post and.
Well, thank you very much for that. I shall
as a clinical teaching fellow at the general surgery at Broomfield Hospital in the UK, where she also works as a junior doctor and also clinical lecturer at the university. So many thanks.
Or this. So this is about a 68-year-old male presented with a complex abdominal wall hernia for repair. Regarding his past medical history, it was only morbid obesity with BMI of 44.7. His weight was 124 kilos. He was not smoking. It's not diabetic, so it was red mass. 1 year later, he had an epigastric and paraumbilical hernia. Repairs. January of 2019, he had an exploratory laparotomy with small bowel resection for incarcerated right inguinal hernia. And 10 months later, this inguinal hernia was repaired with Prolene mesh now. So when he had the first visit to our clinic, you can see that he was presented with 3 hernias. So he had a large left hernia, 30 by 36, one large candidate 2 as per VWHC because of patient's obesity. So the initial plan was to attend the rehabilitation clinic, which includes an 8-week program with nurses, physiotherapy, and dietitians. This is to promote behavioral changes such as increase in physical activity and weight loss. So the patient was encouraged to reduce size. And 14 kilos in 8 months. After that, Botox injections were administered 6 weeks before the operation. And then progressive preperitoneal pneumoperitoneum procedure was performed with an invasive filter preparation before. This was to allow the gradual enlargement of the abdominal cavity. increasing in this way the likelihood of fasciitis. The program with the incisional hernia with the use of fasciotense. Starting the operation with an elliptical midline and elliptical lateral incision in order to create an L-shaped incision, as you can see in the picture. So after managing to enter the peritoneal cavity and release an adhesion of bowel to the abdomen into recto-rectus space. Space was developed from epigastrum down to behind symphysis pubis and laterally till the edge of anterior and posterior rectus sheath. The recto-rectus space after dissection was 30 by 15 centimeter. Then the posterior sheath was closed, and the fasciitis meg. Then we continue with the next part of the operation, which was the use of fasciotense with vertical traction in order to help with the abdominal wall traction. In this way, the abdominal closure can become easier and it reduces the need for mesh bridging or component separation. In this way, complex hernias or open abdomen can be directly closed. So we started preparing for the fasciotense, and in our case, we used 10 kilogram. So you can see again the fasciotense, and then we continued with the last part of our operation, which is the closure, deep dermal sutures, and then triomonogrel for subcuticular to skin. So the patient recovered well. There were no issues. You can see the post-op pictures. So his quality of life was improved. He was enjoying life again. So about this case, the key points is that the attendance to rehabilitation clinic, Botox injections, and eTEP. Thank you very much.
Thank you. That was a wonderful presentation. I get the questions coming. I think we have Sanjay Sonar from our IAGS. He does also, I think he has joined, and along with that, Thangavelu and also Ganesh. Please, son, there be increase in the abdominal pressure or wound related.
So, Mr. Chintapatla can maybe discuss any case.
Okay. With regards to fasciotense, we are learning at the moment. The whole In the absence of facial component separation was the way forward. I like fasciotens because it avoids destructive surgery. Reeve stopper plane is an anatomical, beautiful plane without destroying either an output. So far, collagen-based research to try and find out if weakness of body-based collagen is an issue. So far, we've not got extra results to publish. We found more elastin in these patients in the linea alba. I have not seen any worrying problems with abdominal distension. Ileus with it happens because I'm using negative pressure on the wound on the close suction. Arms break up.
Thank you. Wonderful.
But
And
yes,
why not any polypropylene mesh? Why face this?
so in ventral uh, hernia working group grading 3 and 4 with stomas or small bowel risk. Yes. Yes, because I have extremely complex, I think, large incisional hernias. If there is a recurrence, it will sure be sent back to me. It's your problem. You solve it. Little less than 10%, which is what is quoted.
That's a very good number. Very nice.
Thank you. Guys meet in the ALSJ GBI. And we wish once we test the notion happening in February 2026, please put it in the calendar. We wish to see you there.
Thank you. I'll look forward to. Thank you.
He's certainly attending that. You need his visa out. The presentation. I'm just curious about this fasciotens. Basically, we were taught when we do hernia repairs, it should be tension-free repairs, and if you're using something to stretch to get the length.
Saker, so I'll pick that. It's unfair to put LP spot.
Yes, you can try.
Yeah, absolutely right about tension-free repair, and it's a judgment about how much is tension-free, and you can't do the closure and separation in order to get a tension-free. This seems to provide tension-free without doing a destructive surgery. In my head, that's the big advantage. Of course, in open abdomens, that's a different. It also seems to help reduce intra-abdominal hypertension, stroke compartment syndrome.
Just to just to follow.
Tom McLeod used to use some amount of traction on subcutaneous fibrotic areas to improve this. I guess
Final question, Srinivas, with I don't know how many we have been having some encouraging results from physicians from what the consultants across India. What's your view? Is it here to stay? And the results are encouraging from the caseload you have seen in the lately, or including the
so. Gary, Lil is a really tissue tends a lot under direction when he comes the little things he does when to help us with those cases. So I think it's here to stay. That's my personal view, not data driven, because there is a lot more data to be entered. We have gone down. The British Hernia Society has started its registry in November. All the cases are being entered, but it's not yet mandatory. Once governments say you have to put, then that's when fascia tense data is being collected as part of that registry, and time will tell us.
Thank you. Thank you. I think we are doing well. We have 3 more minutes as for the Dono's target. We have Graham Whiteley to have some final words from ALSGBI. Then I would be inviting our incoming president of IAGS, Satish Mida, to do the vote of thanks. Over to you, Graham.
Well, thank you very much. It's been, I found an excellent presentation. I did have one little question for Srinivas in terms of his preoperative and postoperative dynamic imaging. Does he always do that, or is there a certain size when he says, I can cope with that myself? And does he always use a plastic surgeon? I'm a firm believer in TAP. I've always done TAP rather than TEP because I didn't like bleeding in a very enclosed space with a TEP. But I've learned a lot from this. I've also learned about fascia tens, and it's on the up. If anybody wishes to answer the questions, fine. Otherwise, thank you to all the speakers. Very entertaining, very informative as ever. Thank you.
I can pick up on what you asked, Graham. The kind of caseload I have is large hernias, extremely large ones, and the plastic surgeons are such a delight to, they get better results than what I can achieve. So that's why I get them involved in this thing. You asked about TAP and bleeding. I love doing TAP surgery, very fine, very delicate, and I enjoyed the case that Nidhi presented. She talked about bleeding, and I like that idea. Prevention is better than cure. So as you, I always try to do everything to not have bleeding rather than deal with it. So yeah, it's lovely to be here.
Graham, I think there's a question from Shafaq, I think. Am I right?
Yes, it was just a very little question about meshes. And I'm trying to say that in a controversial way because mesh is probably a subject in itself. But it's about the phasix mesh. I just wanted to know, has there ever been any complications you noticed with the phasix mesh? Because there have been a couple of cases presented in our organization where, because of the nature of the mesh, where one side doesn't stick and the other side sticks, in the retrorectus space, actually didn't take with the posterior fascia, and bowel herniated, and they represented with a hernia, but not a complete recurrence, but underneath the mesh. So don't know if you've ever had any experiences around that.
Yeah, yes, I've been using Fisherton's for about from 2015 or so. I have had 2 cases of very bad infection out of about 100 or so. Not all of the big cases had phasix in. So the issue in those 2 cases was, one was a person who was rheumatoid arthritis on methotrexate, and one was a lady with diabetes and obesity, which were the 2 issues. So I don't know if that's due to the Fisherton's. I've not had a posterior wall rupture, which is the issue that leads to interparietal hernia that you're describing. You don't have a hernia that has got through the anterior rectus sheath, but it has got through the posterior rectus sheath. I've been fortunate. Now here's something, I'm going to say something which is perhaps controversial. I use 2-PDS for the posterior wall this thing. So that's not quite small bites, but it is in the sense that small bite studies are all done on linea alba for 2-PDS and small, but I'm comfortable, and so I use 2-PDS. Whether that helps or hinders, I don't know, but I use small bites for my posterior wall and the anterior wall.
And it may be a combination of a couple of things: is the tension on the posterior wall approximation, as well as the size of the suture. So that was the 2 things that we came up with, is maybe we ripped the posterior sheath during closure with, I don't know, some people still use loop PDS for some weird reason that I don't understand.
I think Greg Dumanian showed some lovely pictures of that buttonholing when you use the number 1 PDS and so on, which is perhaps avoided with small bites and 2-PDS.
Thank you. That is a very interactive session. Let me have a pleasure of bringing our President-elect Dr. Satish Mehta. He's the brain behind bringing our IAGS to greater heights. We are going to the base of the Mount Kailas or Himalayas to have our Nepal and IAGS South Asia conference next, before we come to ALSGBA next year. Over to Satish Mehta.
Good evening, everybody. Thanks, Professor Ishwar Murthy. So at the outset, I would bring greetings from IAGS to all of you. And it is a well beginning of this academic year, calendar year, and we had a good discussion on various aspects of hernias. I thank all the speakers as well as case presenters and all those who were present throughout the session for their inputs, the questions and discussions which we had. So I thank everybody for their efforts. I think we have a long way to go, and we'll be continuing learning, relearning and unlearning in the months to come. So I thank Dr. Thangavelu for coordinating the whole episode, and we'll be further discussing on many other topics in greater detail. Thanks to Dr. Ishwar Murthy for moderating the whole session today. Thank you, everybody, and wish you happy Republic Day. Today we are on the eve of Republic Day. Tomorrow, India celebrates the Republic Day. So with all good wishes, good night to all of you. Thank you all.
Thank you. Thank you, Doc Plexus, for a seamless transmission.
Thank you, Doc Plex also.
Thank you. Bye-bye now. We'll meet again in 3 months' time for another session, exciting session, and another subspecialty. Thank you all. And bye-bye from IAGS. And well done, ALSGBA. Thank you. Bye-bye.
Thank you very
Thank
much.
you.
Bye. Good night.
Night.